Ну, я понимаю, вопросы ответ.
Вопросы? Есть вопросы? Ну, доклад не научный, больше такой торжественный, поэтому, пожалуйста, теперь мы переходим к следующему докладу. Профессор Ю.Рокштро. Современные стратегии лечения ВИЧ-инфекции, ВИЧ и вирусной гепатита.
Esteemed colleagues, ladies and gentlemen, Dobre Utrom, it's a pleasure to be here in St. Petersburg, and I still fondly remember what you called the Red Lady because she was the first one who got me here to speak at one of your conferences. My topic today is strategies for treating HIV and viral hepatitis co-infection. Now, I know very well that you have a lot of hepatitis B and C, so I think this is a timely topic. Let me start with what the guidelines of the European AIDS Society recommend, namely, if you see an HIV patient for the first time, to screen for all hepatitis viruses, so hepatitis A, B, and C, and obviously in the setting of a negative hepatitis A and B serology, you would then recommend vaccination, which is important, and in the case of positive chronic hepatitis B, don't forget that hepatitis delta also needs to be included. The importance of vaccinations can be illustrated by the hepatitis A outbreaks, which happened recently, and you've seen corresponding reports from all over Europe. So obviously vaccination is important to protect. Remember that 2 doses are necessary to achieve high rates of seroprotection. Hepatitis B is a much more commonly found viral infection. The overall prevalence is 257 million. These are the WHO figures, so a very prominent infection, more common than HIV. And you see there is a big distribution throughout the world with the highest amount of infections in the Western Pacific region and African region. There is, due to overlapping transmission pathways, considerable amount of HIV-HBV co-infection. We presume that 6 to 9% of all patients who have HIV also have chronic hepatitis B. Again, vaccination, I think, is the key answer. And you can see in some of the countries where birth date vaccination is available that actually the rates of co-infection are declining as a mere function of having better seroprotection against hepatitis B. Now, one of the important features of hepatitis B, and it's also true for hepatitis C, is the faster course of liver fibrosis and eventually occurrence of liver cirrhosis. So if you have HIV and chronic hepatitis B, you have a 14-fold higher probability of dying of liver disease. And that is the reason why diagnosis and management and treatment eventually of hepatitis B is so important, because otherwise you're going to lose your patient, particularly with advanced immune deficiency, to the sequelae of chronic hepatitis B infection. Now, if you look at old data from the French hospital cohort, and you can see how initially the amount of people dying from end-stage liver disease after 1995 increased substantially. So when HIV became treatable, other diseases became more prominent, and as such, people were starting to die from liver disease. But you subsequently saw a decline, at least with regard to those who were HPS antigen positive, which is a sign of chronicity of hepatitis B. And this was the reflection of the introduction of 3TC. So once agents became available for treating hepatitis B, there was a significant impact on HBV-related mortality. So this underlines how important treatment of hepatitis B is to prevent dying from liver disease. The issue with 3TC therapy, though, and the same holds true for FTC, is that it has a high rate of resistance. After 2 years, you can see around half of all patients who receive 3TC and have HIV and chronic hepatitis B will develop resistance against 3TC. So that is no longer a recommended option. And you can see that the resistance rates, even after 5 years of treatment, are much lower for entecavir and tenofovir. So these remain the two potential options for treatment of hepatitis B in the setting of monoinfection. But remember that entecavir has activity against HIV. So if you have someone who has HIV and HBV and you would give entecavir monotherapy, you would induce HIV resistance with an M184V mutation. So the guidelines in the context of the European AIDS Clinical Society are very straightforward. Anyone who has HIV and hepatitis B should receive antiviral therapy that includes either the old formulation of tenofovir TDF or the newer formulation TAF, both which are also available as single agents for hepatitis B monoinfection. But that's really the essential drug, and in case they are contraindicated, then you have to give entecavir with an otherwise fully suppressive HIV therapy to prevent resistance emergence. Now, one of the interesting features of hepatitis B in the context of HIV are, if someone has HIV and gets infected for hepatitis B, his rate of chronic hepatitis B is 6 times higher than in monoinfection. So usually 95% of people clear hepatitis B infection and only 5% become chronic. In HIV, with advanced immunodeficiency, this becomes much higher. So you could at least ask the question, if I start HIV therapy, does that impact through immune reconstitution the likelihood of seroconversion, which you would define as loss of HBs antigen and eventually formation of anti-HBs antibodies? And most interestingly, in this larger cohort from Germany, you can see that indeed in almost 360 patients, the seroconversion rate over time, up to 41 months in median, was 18.4%. So indeed, if you start a patient with HIV and chronic hepatitis B on HIV therapy, you may actually achieve seroconversion. And this is very stimulating because it tells you that some patients can clear infection, and if you could study the antibody response and the immune mechanisms behind that, you may actually be able to work on the hepatitis B cure agenda. Another important issue is that with the introduction of TAF, which is the new formulated tenofovir, which comes with a different prodrug, the alphenamide prodrug, which allows better direct transport into the cell where it's phosphorylated and active, you only need 10% of the previous tenofovir plasma exposure, so you have less renal and bone toxicity. But you can also see that it has great hepatitis B activity, so in all dually infected individuals who receive TAF, they achieve well control of their hepatitis B. But note that if you start someone on dolutegravir or bacillus 3TC, so you only have 3TC as your component of an HIV therapy in a non-vaccinated patient, there was one case of active HBV infection. So 3TC alone does not protect against hepatitis B infection if you're not vaccinated correspondingly. So one of the other interesting issues around HIV patients who have a negative hepatitis B serology, so if you go into large cohorts here from Amsterdam, and you look at men who have sex with men where there's a risk of acquisition of hepatitis B who did not get vaccinated, those who received tenofovir as part of their HIV therapy, none developed a hepatitis B infection, whereas there were some in those who received only 3TC or FTC, and there were quite some infections in those who had no HBV active drug. So the message is, in case you don't vaccinate or vaccination does not work, at least giving tenofovir as part of your HIV regimen will protect the individual for subsequent HBV infection. And one of the important issues around hepatitis B, also in the context of dual therapies or nuke-free therapies, but also in the context of immunosuppression through chemotherapy. And remember, as has been highlighted in the wonderful overview of the research program, the new role of comorbidities in HIV, cancer becomes a very prominent feature of these complications. So you're more likely to give increasing numbers of chemotherapy, And obviously in that context, particularly when you use rituximab, which would be a standard element of non-Hodgkin lymphoma treatment, for example, then you can get reactivation. So if you had a past infection for hepatitis B, anti-HBC antibody and anti-HBs antibody positive, and you give rituximab, you can get a flare of hepatitis B in the setting of chemotherapy. And so in that case, you would also need to prevent reactivation by giving tenofovir or entecavir correspondingly. So let's move to hepatitis C. Hepatitis C, from an epidemiological standpoint, is also a very important viral infection with around probably 71 million infected worldwide. There is a considerable overlap with HIV co-infection, around at least minimum 2.3 million co-infected, and you can see there is a big number of infections, again, in Asia and Africa, but particularly in Eastern Europe. So that's where the highest burden is, and you know very well that the groups of patients, in particular, who get their HIV infection through IV drug use are very likely to have a very high rate of hepatitis C, usually in the range of around 80%. So that's something you're going to see quite commonly. And just as in hepatitis B, the rate of fibrosis progression, the rate of cirrhosis development, and the risk of dying from liver disease is considerably enhanced in patients who have hepatitis C and HIV together. This is data from the very large EuroCEDA cohort, something where some centers here in St. Petersburg have also contributed data to, and you can see that the highest risk is in those who have hepatitis C antibodies and signs of ongoing replication. So RNA positive, there was no impact of genotype, but clearly your risk to die from liver disease is enhanced. And so the question then was, again, if I give HIV therapy, prevent immunodeficiency, which promotes fibrosis progression, can I then revert the course of liver disease back to the more favorable course of monoinfection? But you can see here from this American analysis from the veterans cohort that even in patients who had suppressive HIV therapy, the rate of liver decompensation remains higher, so it's still a shorter time to hepatic decompensation for patients with HIV and hepatitis C, particularly for those who had a CD4 count below 200 and ongoing replication. So really, again, re-emphasizing liver disease remains unfavorable in the setting of dual infection with hepatitis C and HIV. The European guidelines list a whole range of different direct-acting antivirals, so clearly the success story of antiviral therapy for hepatitis C is quite amazing. We now have a whole range of different options. You can see all these different regimens listed for genotype 1 and 4. Very, very many options, and then somewhat less, but still enough for genotype 2 and 3. Clearly the pan-genotypic regimens, in particular the GP regimen and Sofvel, have become the dominant regimens used because of their pan-genotypic activity. Now, it's not so important which regimen you use as long as it fits the genotype your patient has, but the important thing you need to think of in the context of HIV is the risk of drug-drug interactions, and there is an excellent website for that where you can check drug interactions between hepatitis C and HIV drugs. And I've listed in this table the most common side interactions. So you can see that in particular regimens which include a protease inhibitor, so gozapavir, voxeprevir, and glucapavir, have quite some interactions with HIV protease inhibitors. But remember that in the context of the NS5 inhibitors, which usually have little interactions, velpatasvir sticks out because it does have an interaction with efavirenz. So you have to sort of check in this website, is the HIV regimen the patient is on suitable for DAA therapy? Remember that most of the non-boosted integrase inhibitors, so bictegravir, dolutegravir, and raltegravir all go very well. Nucleosides on average go very well as well. So you have options, but you have to amend potentially your HIV therapy correspondingly to your choice of DAA therapy. The important message of all oral DAA pan-genotypic regimens is very simple. The efficacy is high. It's comparable to monoinfection. On average, 96 to 97% of patients are cured after short cycles of treatment, so something between 8 and 12 weeks. And that includes prior treated patients with interferon, includes cirrhotic patients. So the response rates are really impressive. This is from the more recent ASTRAL-5 trial of co-infected individuals with HIV and hepatitis C, including genotype 1 to 4. And you can see whether they had cirrhosis at baseline, yes or no, previous failed interferon-based regimen, yes or no. The cure rates are very, very high and reassuringly. So basically, we have very simple oral regimens now, which can be given and achieve cure in pretty much every individual. And that comes at very low price of adverse events. You see the discontinuation rate because of adverse events for all the different regimens is extremely low. There's a little bit of GI toxicity, maybe some headache, but in general, great tolerance. And so as such, treatment of hepatitis C really is no longer a challenge. And as this is the case now for the last 3 years, we asked one of our students for his doctoral thesis to look at the patients in our cohort in Bonn. And you should know that in Bonn, the specific feature of this relatively small university city is that the world's largest hemophilia group is present there. So we had a large number of hemophiliacs, and you know that hemophiliacs also have quite considerable amounts of hepatitis C. So that explains why we have a relatively high burden of hepatitis C in our cohort, with around something a little bit about 400 patients, which were analyzed. And you can see that by now, pretty much every patient has been treated and been cured, and there are only 32 untreated left at the time of the analysis. And the reasons for not treating them was either they were just newly infected and were in the phase of deciding should they be treated now, yes or no. We had 3 individuals out of all of the patients we treated who failed their dual DAA therapy. All of these 3 individuals have now been retreated, and you know there's a combination tablet with sofosbuvir, velpatasvir, and voxileprovir, so it's a 3-drug class DAA therapy, and all of the patients have been cured. So they are no longer replicating. Some had other interventions, hip replacement, or other things which refrained them from getting medication at this point. And then we have the largest groups, which were long-term loss to follow-up or non-compliant. So these are mostly active drug-using individuals, which are just difficult to recruit to medical centers and get to adhere to an 8 or 12-week therapy. So really, the amount of hepatitis C patients has become 0 in those centers. It's really more now a question in the German context to find the people who have not been diagnosed so far. And then there's a remaining issue with the outbreak of acute hepatitis C in men who have sex with men. Looking at a much larger scale in the context of Spain, and remember that in the old days when the HIV epidemic began, very similar to your own epidemic, IV drug use was the main driver of HIV, and as such, 50% of the patients in the old days had, or 60% even had hepatitis C antibodies. So there was a huge amount of dual infection in Spain for that very reason. And with the introduction of these effective hepatitis C therapies, you can see the number has steadily come down. And from maybe 55% of patients replicating in 2002 for hepatitis C, this is now down to 8%. So you can see how countries are very close to elimination of hepatitis C after successful rollout of therapy, and this goes very nicely in hand with the uptake of hepatitis C treatment. So I think many European countries are currently facing the potential of achieving the hepatitis C elimination goals, at least in the context of HIV co-infection, because these patients are much more easy to identify and to treat. The remaining challenge for many Western European countries is the outbreak of hepatitis C in men who have sex with men, mostly through traumatic sex practices. And so some of these countries, Switzerland, Netherlands, and now London, have offered immediate treatment to these individuals. And most interestingly, with the global access of hepatitis C treatment in these newly diagnosed and treated patients, they saw an over 68% reduction in new infections. So actually treating acute hepatitis C in an outbreak helps to eliminate hepatitis C, prevent new infections. And so I think this is also a good way forward to potentially get control of this ongoing epidemic, which is occurring in many places in the world. So in summary, I think we've seen a significant reduction in liver-related mortality in HBV co-infection. Once we introduce HBV-active antiviral therapy, if you have someone with chronic hepatitis B, tenofovir, either TDF or TAF, it's clearly the first-line regimen and should be started irrespective of the CD4 count. In patients who do not respond to hepatitis B vaccination, tenofovir containing antiviral therapy can prevent new incident HBV infections, so at least get protection through that. Every person with hepatitis C co-infection should be considered for DA therapy. I've shown you the higher success rates, 97%, and elimination, I think, is possible in that setting. The drugs we use are the same as in mono infection, but you have to check for drug-drug interactions. So with that, I'll thank you for your attention and invite you all to come to the European AIDS Society meeting, which takes place in Basel from the 6th to 9th of November, and I hope I see many of you there. Thank you very much. Yes.
Thank you very much for the brilliant presentation. Jürgen, thank you very much for the brilliant presentation. One question. Why you didn't show the results from the trial with GP combination in HCV HIV co-infected patients?
Yeah, so that's right. That's the only one missing, but it has absolutely the same response rate. So in the end, I would say it doesn't really matter which regimen you take, because I know that every country has different options. The GP combination has one advantage, which is that you can use it at a shorter duration of 8 weeks. And for some patients, this is at least an advantage with regard to adherence. So a lot of the NIH studies in more challenging patient populations have shown that after week 6, adherence declines. So if you have a challenging patient population, I think some people would lean to the GP combination because of the shorter treatment duration. Remember, there are 2 things, though, about GP you have to know. It's contraindicated in the setting of child B cirrhosis and child C cirrhosis, so you can't use protease inhibitors. That's true for other combinations as well. And you have maybe a little bit more drug interactions with regard to some of the HIV protease inhibitors. But remember, again, integrase inhibitors work very well, and that is the current recommended first-line regimen, so I would say it's